So I have a few disclaimers. First being, obviously, by now it's obvious that I'm not a pediatrician and I don't have to claim any pediatric experience at all. It's primarily based on the patients with a spectrum of pediatric patients who have been referred to me over the last 15 years that I'm basing this talk on. And also, straight off the bat, because this is going to be the most pressing question, biologics are not licensed for people less than 12 years, except mepolizumab, which is licensed for 6 years. Omalizumab is another therapy for which there is data for 6+ years, but it's not approved for that age group. So now we'll start with the case. Now I had, this is somebody that I saw 2 years ago. So this is a 52-year-old lady who was actually had a symptom for a year, variable symptoms, and also spirometry showing features consistent with asthma. She also had rhinosinusitis, polyps, and anosmia. So she did not have any prior severe acute exacerbation needing ICU admission or hospitalization till date. She had no childhood symptoms or any family history. She was a retired nurse with 2 children. No significant biomass fuel exposure, pets, or passive smoking exposure. Lab showed eosinophilia with a mild rise in IgE, with a significant elevation in Pheno. X-ray was normal. She was at that time on 800 mics of budesonide and 24 mics of formoterol per day, with with good compliance and good technique. But she continued to have 2 exacerbations in the last year requiring oral steroids. Still no hospitalization or ICU admission. In between these episodes, her symptom control was pretty good, with good control of asthma, but her anosmia persisted. Her PFT showed fixed airway obstruction. So at this question point, the question raises, what are the options for this patient? And these are some of the options that came to mind. So after the end of this talk, we'll then come back to the same scenario to see how we can solve this patient's problem. So I'll only try and cover 5 headings, and my aim is to sensitize some of the things which have changed in these 5 headings. And then we'll take them one by one. Each of these headings are themselves big topics, and I'm only trying to sensitize especially junior people who are onto this meeting. So first and foremost, why should we individualize asthma phenotypes at all? So if you look at the definition of asthma as we currently understand it, the definition itself explicitly states that it's a heterogeneous disease. Now then, this disease is usually characterized by, but not always characterized by, airway inflammation. So the definition accepts that there are patients who have this heterogeneous disease without airway inflammation as well. Now, this disease is characterized by variable symptoms and variable airflow limitation. However, again, the definition says that if you see them later on, this variable airflow limitation as well as the variable symptoms may become persistent. So if you actually were to describe a new disease like this these days, you would never be accepted by the medical community at all. Meaning to say that this is something that is quite a polymorphous kind of disease. And the nature of the disease is the reason why it's so polymorphous. So there are host factors and there are environment factors. The genetic factors are quite different between individual patients with different gene groups responsible for expression. The environment is also different, with some people having predominant exposure to allergens driving their problems, some people having non-allergen driven problems, and some people having infectious diseases triggering their symptoms. These gene and environmental interactions lead to differential expressions of protein in different patients. Some people have an inflammation which is driven by the eosinophilic pathway. Some people have inflammation driven by the neutrophilic pathway, and increasingly there is recognition that few people don't have both pathways involved, and it's primarily derived by epithelial alarmins in these people. So this leads to variable symptoms in different types in different patients, leads to persistent airway obstruction in some people, leads to airway remodeling of various degree in various people, and leads to variable effects of therapy in most people. For example, if you look at one of the very large recent trials published in NEJM, so this is a landmark trial called the Sigma trial. So this trial looked at patients with mild asthma. And then you may say, why is there need for a trial for mild asthma? The reason for treatment of trial for mild asthma is that mild asthma contributes to majority of the patients with asthma, 80%, and then it's often not seriously taken, and then 25 to 30% of all hospital admissions are because of mild asthma. So this was kind of a landmark trial, which one of the 3 trials published around that time, which changed the paradigm for treatment of mild to moderate asthma at this point. And then we don't use the term mild to moderate asthma upfront. We use that as a retrospective diagnosis. So this trial enrolled mean of adult patients primarily. Most of them were non-smokers, had symptoms of asthma for about 7 years and fairly good lung functions. At baseline, most of them, about 80% didn't have an exacerbation. Having said that, 22% had an exacerbation 12 months prior to the enrollment. Clearly stating what kind of the same figures that what I quoted to you now. So these patients were treated with 2 kind of approaches. They were treated with the formoterol budesonide as and when needed, or budesonide twice daily. So over the period of this 12 months that these patients were enrolled in this trial, 8.8% continued to have exacerbation in this patient, even though this was lower than the historic control, which was 22%. Despite that, 8.8% continue to have exacerbation while on a regular budesonide arm. So, which means to say that 1/3 of the patients that who on treatment who kind of do not show a response. So, 8% out of 24% will not show a response, or overall out of a cohort, 1 in 12 may not benefit from steroid. And then there are certain genetic links which are linked to the response to steroid, which is well described. So the response to therapy as well, again, is not universal. So all this led to a long-standing debate in the respiratory communities. Some people, in fact, have gone on to write editorials, highly controversial, in Lancet, no less, that asthma as a disease concept itself should be abandoned, and then we should use a treatable trait concept for asthma as a disease rather than a concept. But that would be an extreme view. There is some definite clinical value in continuing the clinical label of asthma, and you try and see how to manage majority of the patients using this shared moniker. So how do we recognize asthma phenotypes? So the current algorithm core involves these 3 steps management. That is, we first assess the patient, confirm the diagnosis of asthma based not only on history, but absolutely requires spirometry. In a majority of the patients requires FEV1, but you can use PEF variability as well. So you also assess symptom control based on the 4 simple questions that you ask patients as to what the daytime symptoms are, what the SABA use over the last week has been, and over the last 1 month has been, how limited are there in the daytime activities, and then what are the nocturnal symptoms. Based on these 4 questions, you put patients into whether they are well controlled or partially controlled or poorly controlled. You assess their lung function and then the long-term risk of disease, which is primarily dependent on the lung function. And of course, the short-term, which is based on the prior exacerbation. One assesses the comorbidities, the correct dose, whether it has been given, and then whether it's been taken correctly, both in terms of adherence as well as in terms of technique. And ultimately, it's a shared conversation. So what our goals are and what the patients and parent goals are have to align for these patients. So once we've assessed this, and if we see that both they are not on the same page, then we try and modify not only asthma medications but also several non-pharmacological strategies, which could involve reduction in allergen exposure, non-allergen exposures like passive smoking, etc., or even active smoking in adults. So these kind of things, and of course, apart from education and skill training, which need to be imparted at every visit, and of course, looking at other modifiable risk factors. For example, Dr. Ilamaran pointed out obstructive sleep apnea in one patient. So chronic sinusitis and GERD are the single most common modifiable risk factors in patients with asthma. Of course, other factors like depression, obstructive sleep apnea, and all are significant risk factors, which often lead to significant symptoms without effect on lung function as such. So one needs to look at these, especially if there is an imbalance between the patient's symptoms as well as the lung function. So over the period of time, then one reviews these 5 things: symptoms, lung function, exacerbation, side effects of treatment, and what are the patient's goals and satisfaction. So this is the current algorithm core. So based on this, the the algorithm for patients who are 6 to 11 years. And the reason why I chose 6 years, and this is there in the GINA guidelines, I'll come back to. But then the algorithm primarily goes through a stepwise approach. And then the stepwise approach for pediatric patients is slightly different from the stepwise approach for adult patients or those who are more than 12 years. For pediatric patients less than 12 years, the approach is primarily to use a low-dose ICS and SABA whenever ICS is taken. That is still the primary approach. And then a regular ICS in step 2 if they have symptoms more than twice a month. Low-dose ICS LABA if they have more frequent symptoms, meaning symptoms every week. And medium-dose ICS LABA as we go up. And only in step 5, in this, there is a role for phenotypic assessment, which is the focus of this topic. And then when you say what is low dose, medium dose, and high dose, it's important to remember. Now, this is a lot of information, but what I want you to focus on is primarily what is commercially available. We have budesonide and we have fluticasone. So anything more than 400 mics of budesonide is high dose for children. And anything more than 200 mics of fluticasone is high dose for children. So this is what I want you to focus on. Very rarely people use mometasone, and for most, for example, is an inhaler that is mometasone, and that anything with more than 200, that is high dose. So that foremost is usually actually available only as 200 mics puff. So anything more than a single puff per day is itself a high dose mometasone inhaler. So this is all important for you to keep a watch, because the definition of uncontrolled would depend on what dose of steroids you're requiring as well. So this I already briefly highlighted that the paradigm for adults has changed, and one of the trials which led to this change I've already presented. Now the paradigm for adults is that the constant ICS paradigm has gone out, and the paradigm is primarily based on a low-dose ICS formoterol paradigm. So in steps 1 and 2, which is conglomerated, we use as and when required. This is a smart therapy. We use a regular kind of therapy when it goes to more frequent symptoms, that is a weekly symptoms. Then we go to a regular maintenance plus reliever ICS formoterol. And the reason why formoterol and not salmeterol is used is the speed in which formoterol starts to work. And then we go from a low dose to medium dose ICS formoterol based on the doses that I'm going to show you now. And again, step 5 is when you kind of phenotype these patients. So you don't phenotype everyone straight off the bat. And of course, the other difference is the kind of other approved therapies are slightly different in adults more than 12 years. And these are doses. The doses are roughly 2 times the doses of in adults, except that fluticasone is 500 and not 400. So that's the only kind of difference here. Finally, one word about children less than 5 years. Now, less than 5 years, you can see that it's quite difficult, of course, to often make a diagnosis of asthma. It's often a tentative diagnosis, especially those who are between 3 and 6 years. Infrequently, you don't even make a diagnosis, but you make a diagnosis consistent with asthma, and then you start on SABA initially. When there's not much relief, then you start low-dose ICS with SABA. And then at this point, you refer, and then because none of the other phenotypic therapies or otherwise are approved for this age group, that is not in this paradigm at all. The definitions for or recommendations for steroid doses for less than 5 years are very important. And you can notice that actually at 1 year and above, the only approved therapy is budesonide, and that is 500 mics per day. The other common thing that is used is beclomethasone, which is Aerocort inhaler. That is a standard dose particle inhaler. That is 100. That anything more than 100 mics per day for less than 5 years itself becomes high dose ICS. The extra-fine inhaler has kind of come into the market over the last 4 years. The inhaler is called Individualize. It's sold by Cipla, and the extra-fine dose is 50 mics here. So we saw about step 5 therapy in the adult paradigm, and step 4 therapy in the pediatric paradigm. So when we're speaking about that group of patients now, so what about phenotyping? And then this phenotyping is not something that is new. The first word about phenotyping started way back in 1949, and this is the paper that first looked at phenotyping, and then they described the thing of extrinsic asthma and intrinsic asthma, which used to be described by Davidson's textbook of internal medicine. these earlier on. So that kind of led to more refinement in the early 2000s with more recognition of physiological phenotypes, trigger phenotypes, and inflammatory phenotypes. And this is one of the very initial paper from Sally Wenzel, which brought out this paradigm. As more data emerged that, when you use the patients that you see in clinic are not representative of the entire cohort of asthma, obviously. So then there became interest in data from unbiased collections of patients. So there are three main studies which have looked at, patients, and as there is no study which is truly unbiased, they are unbiased only to a certain degree, of which the Sarc study is something that we will spend a little bit time on. Now, this study it's important because now it's running for 20 years and it's now in its third iteration. The first and second iteration, which I've highlighted by saying 1 by 2, enrolled only 40% of patients with severe asthma. So that itself is an overestimate. We know that severe asthma contributes to less than 4% of patients with all asthma. So that's where the bias starts. But, there is important information in this from the study coming out. They looked at 34 variables, and then they found that 11 of these were able to classify patients into 5 clusters, which were quite distinct from each other. They were able to classify majority of the patients in their study, which is initially 1,600, but then now subsequently around 2,400 patients. They also looked at gene type expression based on mucosal gene expression. They found that commercially used blood tests, Pheno, IG, and all led to wrong classification 25% of the time based on gene expression. And then this is the type 2 gene mean, but that was high in 55% of their patients in their cohort. So this is all very useful information as we go on to the subsequent slides. So overall, from this study, the Sarc study, they were able to classify into 5 separate big cohorts. You can see that basically it's all early onset asthma, which is atopic, which can be mild, moderate, or severe. There is, of course, a subset of patients with severe fixed asthma, which is often late onset. So that is something which came out very good, very well in this cluster. And specifically as pediatricians, if you look at what is the cluster across age group, you can clearly see that this atopic asthma was there, which is there, this present in adults as well as in pediatric clusters. So there is a group which started at less than, 3 years, which kind of went into remission at this point. And a part of this cohort kept on having symptoms up to 3 years. And then this part of this group, which started around 1 to 3 years, went on to have symptoms till 12 years, and then went into remission around that time. And we know that about 50% of these patients again have symptoms in adults as such. What was also seen in the Sarc group was that there is a subgroup of patients who had both a late onset asthma, which was not characterized by much inflammation, as well as an inflammation which was early onset but had persistent symptoms and persistent lung function decline. That is important to recognize. So the next, how can we phenotype patients based on the inflammation that they have? So inflammation in asthma is heterogeneous. We've already talked about this. And it's not only driven by allergens and viruses, but also driven by a lot of pathogen-associated molecular proteins, which we PAMPs or alarmins. These induce epithelial interleukin 33 production, TSLP, which is thymic stromal lymphopoietic protein. These kind of activate dendritic cells to present that particular epithelial as well as the antigens to T cells, leading to long-term memory and B cell production, IgE production, switching, and lead to persistent asthma phenotype. So this can occur through the standard interleukin 4-5 pathway. This can occur independent of the interleukin 4-5 pathway, and both of these can lead to the same final destination. That is why now it is not called Th2 high. It is now called T2 high, because the Th2 helper cells are not involved primarily in this epithelial alarmin. It's primarily the dendritic cell which drives this pathway. And of course, there are a small fraction of patients who do not have these particular things driving their asthma, which have muscle protein or neurological factors driving their asthma as well. So these are polygranulocytic or polyinflammatory type of asthma. And we already spoke about the Sarc cohort and the gene expression, and these are the 3 genes which are usually kind of elevated in patients with type 2 high asthma, which is the periostin gene, serpin-2 gene, and the calcium gene in the epithelium. And in the Sarc cohort, I pointed out the expression was high in 55% of the cohort. In this study, in published landmark study again published by Woodruff in AJRCCM. This was around 35% of the cohort. So the current algorithm, which is driven by Gina, primarily focuses on the Th2 inflammation. Of course, we have to increasingly recognize that Th2 inflammation persistent is seen in less than 1/3 of patients. The majority of the patients that we see would have a T2 low asthma in 50 to 60% of the time. And of course, 5 to 10 will have a purely non-inflammatory type of asthma as well. And therapies historically for this kind of patients have been underprivileged. We've been hitting these patients with inhaled corticosteroids without any basis, and phenotyping these patients is important also to withdraw the ACs that we're excessively giving these patients. So to summarize, if you look at symptoms and onset according to age, whether they're childhood or adult, whether they have T2 high or T2 low, patients can have a different kind of subcohorts. In T2 high, in early onset childhood or adult onset T2 high asthma, you could have cohorts of allergen-driven asthma, which is atopic asthma, aspirin-related or exacerbated respiratory disease, including asthma. You could have a late onset eosinophilic asthma or exercise-induced asthma. These are the broad cohorts of patients. In T2 low, which is predominantly tends to be in adults, we have late onset, especially women who tend to be obese, have more GRD, more symptoms, and poor lung function, but not necessarily poor, significant inflammation. Kind of asthma, and of course, asthma which is triggered by smoking and other exposures, and asthma which is polychronic. So we've spoken about all of these things. Then next we go on to what are the laboratory values which help us to phenotype asthma. So it's important because there is not a single Venn diagram. There are different tests, and then they lead to different aspects of the elephant that we are seeing. So for example, if you had to, the ideal test would be to look at the gene expression, and that will lead to phenotyping correctly in majority of the patients. Unfortunately, this is not available at the bedside and in out of research settings. So that is something that we will not have access to. If you look at the sputum tests, and sputum eosinophilia by definition more than 2%, that is the gold standard test for definition of T2 high. Now, majority of the labs will not do sputum eosinophils for you, and it's very poorly standardized. So unfortunately, again, this is something that is not widely available. So what we bedside used as the serum eosinophils. Now, here the definition of the 300 has been used, and studies have shown 50% can have. The GINA guidelines recommend 150 or 2% as the cutoff for eosinophils, serum eosinophils, to define type 2 high asthma. You can see that the serum eosinophils correlate with the sputum eosinophils only 77% of the time. And then that again itself poorly correlates with the gene expression again. So the more you get away from gene expression, the less likely to be, a misclassification error in the basis of your classification. The other thing that we commonly use is something, the fractional exhaled nitric oxide percentage. We use 20 as the cutoff. Some labs use 25 parts per billion as the cutoff. And then if you use 25 parts per billion, you have a AUC of again around 75 for type 2 high asthma. So majority of the time we use a serum eosinophils or the pheno, and this you are likely to classify 3 out of 4 patients correctly based on this. What I want to also point out is that IgE does not classify patients correctly. So do not use the total IgE to say that this patient has atopic driven asthma. IgE can be elevated whether or not patient has atopic driven asthma. So IgE is a very poor predictor. Do not use IgE, use serum eosinophils or pheno. And then again, this is the GINA recommendation as to how you kind of flowchart patients into whether they have T2 high or T2 low. Same numbers that I've already highlighted to you. So you primarily look at the eosinophils and the which could be the serum, which is widely available, or sputum if you are lucky to have that, and pheno. And then you classify patients based on the cutoffs that I've already told you to T2 high or T2 low. Now again, T2 low is a kind of unserved entity, so it's important to look at other causes for T2 low, which we'll come back to again. But primarily, we need to look at what is driving this: smoking, infection, reflex. These are the things which we need to, or of course, if the diagnosis itself is wrong. Like several of these diseases can have variable airflow limitation. For example, bronchiectasis, 25% of patients with bronchiectasis can have FEV1 variability meeting the criteria for asthma. Does not mean that these patients have asthma. It means that they have bronchiectasis and they have variable airflow limitation. So it is also possible that patients with asthma can have bronchiectasis. So it's important to make the distinction based on the sequence of events in their history. and the diagnosis that we finally make. Okay. So then we finally come to the most important question is how do I manage these patients based on all the tests that I have now currently understood. So the first step, of course, is to know what a patient is. Is the patient truly step 5 asthma or not? And what does this step 5 asthma include? So this step 5 asthma includes 3 group of patients. It includes 1 uncontrolled asthma. So any patient coming to step 5 is uncontrolled. So they have poor symptom control, or they have frequent exacerbations. But this can be present with or without treatment. That is, this can be present the first time that they came to you. So you put them on ICS, the next time they came to you, they will not be step 5. They'll go back to step 1 or 2. So by definition are not severe asthmatics, but they are uncontrolled asthmatics at the point in which you saw them. Now, the subgroup of these patients with uncontrolled asthmatics will be difficult to treat asthma, means that they are again having this poor symptom control or requiring medium to high dose ICS and or even OCS, oral corticosteroids, to keep the symptoms under control and to prevent exacerbations. But then a lot of these can be corrected by looking at the diagnosis, the comorbidities, exposure, adherence, technique, and the right doses. So only a subset of these patients with difficult to treat asthma actually are truly severe asthmatics. That is defined by the ATCRS as this, which is similar to what we've already talked about. So if you look at 100 patients coming to you, 24% will be in step 5, 17 patients will be truly difficult to treat, of which only 4% will be truly severe asthmatics, meeting the criteria for phenotyping and biologics. So how do I manage based on this phenotypic? What are the therapies that are available to me? So this is a summary of all kind of therapies that are currently approved. So on the allergen-driven pathway, you have, we historically, all of us know the IgE-driven pathway. We have omalizumab, and that's been there for 20 years. It's anti-IgE therapy, which is primarily approved for more than 12 years. But then there is data for children more than 6 years as well, on a compassionate use. So this is for atopic asthma with elevated IgE. Now we also have a subset of patients who are non-atopic asthma but have eosinophilia, and that is driven by the other pathways, which is the alarmin pathways, etc. Now these patients recently, there are FDA approvals for 4 therapies, and now actually 5 therapies with December 2021. We have benralizumab, mepolizumab, and reslizumab, which are anti-IL-5 or receptor antagonist therapy. So these primarily target the interleukin 5 driven eosinophilic inflammation. Of course, we have interleukin 4/13 chimeric receptor blockade called dupilumab, which is now into the pathway as well. We also have recently tezepelumab, which is a TLSP antagonist, which has been approved by FDA. Now, recently there is also a phase 2 trial of anti-interleukin 33 therapy, which is into the algorithm now. We're waiting for phase 3 therapy. Similarly, there is this a lot of excitement of this therapy, which is an oral therapy, which is again for T2 high asthma, but is still data on phase 3 trial is awaited. So if you look at how to use all these kind of different drugs in these patients, so the first step, of course, is to make the diagnosis of asthma, look at whether the correct doses of inhaled corticosteroid has been used for them, whether they are adherent with the therapy, whether the technique is right, there are no comorbidities and other things which are and exposures which are worsening the asthma. That is the first 5 steps, and which is not there in this pathway, which is already there before this pathway. So when you reach these 5 steps and then you made this diagnosis, you assess the severe asthma phenotype based on the biomarkers we've already discussed on. You classify patients as to whether they have T2 high or T2 low asthma. If they have T2 high asthma, then the first question is you have is, can you consider, is there adherence still an issue? Is the technique still an issue? Or is there something else which is triggering the T2 high inflammation? And you still try to rule these out before going into biologic therapy, which is expensive, these patients. And if you consider all of this and none of this is there, then you're at a stage in which you got to look at biologic therapy in these patients. Now, on the other hand, if you don't have T2 high inflammation away in your patients, which is 50 to 60% of the time, you look at again whether obesity is driving, GRD is driving, chronic bacterial infection is driving, bronchiectasis is driving. What exactly is driving their inflammation in these patients and the exposures? And you evaluate these patients in more detail, and then we consider therapies based on what the age group is and what is possible. The options would include primarily azithromycin, will include LAMA, which is tiotropium, or thermoplasty. In patients with T2 high asthma, we have the primary options are now commercially available launched in India are whether it's based on allergen-driven or whether it's non-allergic eosinophilic asthma. If it's allergen-driven, you primarily focus on omalizumab for these therapies and for these patients. And then if it's available, Cipla is partnered to bring that in India. Again, for patients with non-allergic eosinophilic driven asthma, we have anti-IL-5 therapy, which is mepolizumab and benralizumab, both of which are launched in India. Mepolizumab is launched by the name of Nucala. It's even available on compassionate basis for a few patients. So there is nothing to choose between benralizumab and mepolizumab. It's primarily, based on what is available. But the minimum duration is 4 months for these patients to define as to whether they are, responding or not. And then if generally for anti-IL-5 therapy, one needs to wait for at least 12 months to see if the exacerbation frequency comes down. The primary benefit of all of these therapies is reduction in exacerbations and overall lung function control. Lung function doesn't per se change that much in these patients. Symptoms variably controlled. So the main reduction is healthcare utilization and exacerbation by biologics in this therapy. And then we decide on how long to continue these therapies based on what we've achieved in these patients. So this is the other thing that I was pointing. Even if you're not considering biologics in these patients, it's important to use phenotyping because phenotyping doesn't correlate with symptoms. So if you could have this concordant group where you have the early onset typical asthma with high inflammation, in which you can titrate, the inflammation based on pheno, and then you can, once the patient is coming down on the symptoms, you can titrate down the therapy. But also you can use the same markers to identify that this patient is discordant. So if the patient has inflammation, not much inflammation, but a lot of symptoms, then it's useful for this patient for actually you withdraw the ICS dose that you're using, because all you're doing is to put a lot of ICS into the airway and then increase the risk of pneumonia. So you withdraw the ICS and then you try and tackle the other things which are driving the asthma expression in these patients. Similarly, you may have a patient with very few symptoms but a lot of inflammation. And then again, as long as the ICS use does not lead to much reduction in the inflammation, then again, putting in too much ICS may not be really helpful. What we need to look at is to whether what else can be useful to reduce the inflammation, and whether this inflammation is actually leading to any long-term dysfunction in these patients, like long-term lung function or exacerbation frequency in these patients. Finally, I will end the talk with 2 slides on what are the limitations of phenotyping. So it's important to recognize that phenotypes may change over time, especially the T2 high. With therapy, as can understand, steroids will inhibit eosinophil in the airway, and then with time, eosinophil's frequency can come down. In fact, T2 low and postgranulocytic tend to be fairly stable, whereas T2 high tends to kind of fluctuate between 50% to 30% over time. The other thing in data, in that trials have not shown that actually the lung function change with therapy varies very much whether it is T2 high or T2 low. So that is again something that needs to be clarified over the long term. So overall, if you take 100 patients in phenotyping, everybody has not been shown to be superior than GINA-based platform for control of patients. So in the majority of the patients, you don't need to phenotype patients. You need to phenotype only patients with step 4 or step 5 asthma. The best method to define T2 high is evolving. Currently, I would recommend using sputum eosinophils, if not serum eosinophils or pheno. Inflammation often doesn't correlate with severity of asthma, so it's important to use this information to look at the dose of inhaled corticosteroid that you're using for your patient. Target therapies are, of course, only adjuncts, and they are not the standalone therapies. So you need to, and then there are significant costs involved in this, so you need to look at that. There are no clear choices at the moment for T2 low asthma, but then this field is very rapidly evolving. So to resolve the scenario, the same patient that we talked about initially, the adult onset T2 high asthma nurse who had 2 exacerbations per year, meaning who had severe asthma despite high dose inhaled corticosteroid and LABA therapy. So this patient, we suspected aspirin related, even though there was no history, based on these late onset nasal polyposis and anosmia. So we chose to do an aspirin challenge test as per protocol. And then we had a significant FEV1 fall of 40% with symptoms when we used the second escalating dose. That is, we started 75 typically. And then If you have lost very strong suspicion, we even use a smaller dose, 37.5. But here we started 75. And then the next dose of 175, 150 led to a significant FEV1 fall, establishing the diagnosis of AARD. So then this patient underwent an ambulatory desensitization over 2 days. Subsequently, she's had one exacerbation over about 24 months, which is significantly lower than her baseline of 2 exacerbations per year. Her nasal symptoms markedly improve, and this is what the data shows. And the data primarily shows that with aspirin's desensitization, what you will get is primarily upper nasal symptoms reduction, whereas the symptom reduction in terms of asthma control may be variable. But overall, this patient did improve significantly in terms of phenotyping this way. So to summarize, asthma is a heterogeneous disease. Phenotyping has a role in poorly controlled and severe asthma. Currently, skin testing, eosinophilic evaluation by sputum or serum, and pheno are the widely used methods. And then based on the phenotypes, you use the specific disease, which is superimposed on asthma to treat these patients. For T2 high and atopic driven asthma, we have omalizumab. For T2 high eosinophilic asthma, we have mepolizumab. For T2 high eosinophilic asthma with polyps, we have pipilimumab. For T2 low asthma, we have LAMA, azithromycin, bronchial thermoplasty, tezepelumab, which is again something that is this. And recently there is a phase 2 trial of interleukin 33, which is promising for this subgroup of patients. Welcome. Any questions? Thank you.
Thank you, Dr. Srinivas, for such a lucid presentation of the different phenotypes of asthma. And you rightly pointed out that there is not much role for this phenotyping beyond looking at certain tests like your routine tests, which you normally do otherwise also, like your serum eosinophils, looking at pheno maybe, and looking at the history and just finding out whether they respond well to the symptoms, whether there are any comorbidities, and controlling the comorbidities and adjusting those. Yeah, the point. Fortunately, among pediatrics, we don't see much of the severe phenotypes. So I think we are still left with mostly the atopic forms and to a certain extent the neutrophilic forms of asthma, especially when they are associated with viral Vs. So, and what is your experience in the use of thiotropium, and what does the what is your experience in cholinergic asthma? Do you see it as something which is unique, or do you see it in adolescents, adults?
That's a very interesting question, because we started using thiotropium way before data actually approved for thiotropium in asthma actually. And then so there is now subsequent lot of data actually in 2 ways. One is actually thiotropium is an add-on therapy for step 5. That is, patients are already on LABA ICS, and then you add thiotropium to improve the lung function and to reduce exacerbations. So that is one way. Because we know that llamas will have an additive lung function, and that is sustained over 24 hours. So that is one way in which it can be used. The other way it can be used is to actually use as a single-day therapy. So in patients who continue to require inhaled corticosteroids and LABA as a continuous therapy, because the moment you withdraw and then you go to as and when required smart therapy, they tend to have more symptoms and more exacerbations. I prefer a single-day inhaler rather than twice-a-day inhaler, and then that is not possible with smart therapy often in these patients. So then what I usually do is use a single-day budesonide with single-day thiotropium in these patients. And then 25 to 30% of patients have a dominant cholinergic tone as opposed to a response by LABA. So those patients tend to do better than the others. This is something that you cannot predict upfront. You just have to use it and see. Some people simply don't, they tell you that, no, I was much better with the LABA ICS. And then they'll go back to the formoterol fluticasone or formoterol budesonide. And then there are some patients who are very happy with their